afternoon to one and all present here. I'm Dr. Kavya from India. Thank you, sir, for giving me the opportunity to present here. Today I'm going to talk about a case report of peripartum cardiomyopathy. We have Mrs. X, 28 years old, married for 2 years. She's a primey, GDM on meal plan, conceived by ovulation induction, came to us for safe confinement. She was booked and immunized outside. First visit to Sri Balaji Medical College was at 40 weeks. Her menstrual history, age of menarche was 14 years, regular cycles with 3 by 30 days, which was not associated with clots and pains. Marital history, married for 2 years, the non-consanguineous marriage. Obstetric history, the first trimester, she was conceived by ovulation induction. The patient was started on tablet Sustain and tablet Ecosprin 75 mg, which was taken till 34 weeks. The rest of the trimester was uneventful. Second trimester, the glucose challenge test was done at 24 weeks, which showed 155 mg per deciliter. The patient was therefore started on meal plan. The rest of the trimester was uneventful. The third trimester, the patient has history of tablet Sustain and tablet Ecosprin, which was taken till 34 weeks. The past history was nil significant. Personal history was normal bladder and bowel habits. Family history was nil significant. On examination, her general condition was fair, afebrile, not pale, not icteric, no cyanosis, bilateral pitting pedal edema was present, CVS RS NAD. Per abdomen, the uterus was term, not acting, head unengaged, and a fetal heart sound was good. The PV, cervix was mid position, external os patelis, internal os admits 2 finger, membranes present, vertex at brim, which could be pushed down, and the pelvis was adequate. The investigations, all the investigations were within normal limit, except her OGCT was 155 mg per deciliter. Therefore, the patient was started on meal plan. And the ultrasound, which was done at 38 to 39 weeks, shows an AFI of 7 to 8 centimeter. The rest of the thing was within the normal limits. Therefore, cerviprime induction was done as the patient was on her due date with oligohydramnios, as the AFI was only 7 to 8 centimeter. After 6 hours of induction, patient spontaneously ruptured her membranes. The PV finding after 6 hours was cervix was 50% effaced with os 2 cm dilated, membranes absent, vertex at -3 station. There were moderate meconium stained LICA draining. Therefore, the patient was taken for an emergency C-section in view of meconium stained LICA with fetal distress. The patient delivered an alive male baby of birth weight 2.8 kg with a good UPGAR score of 8 by 10 and 9 by 10. On third POD, the patient complained of acute breathlessness. On examination, the patient was dyspneic, tachypneic, mild pallor with a bilateral coarse crepitations, extensive crepitations were heard. She was tachypneic with a respiratory rate of 40 per minute, and the pulse rate was 140 per minute, with an SpO2 of 60 to 70% in room air. Therefore, the patient was shifted to an intensive care unit for further management. There in the intensive care unit, the patient was started on injection Laxix, 60 mg IV stat along with morphine for sedation. The echo features were suggestive of peripartum cardiomyopathy with moderate to severe LV dysfunction. The ECG shows sinus tachycardia. Chest X-ray shows bilateral homogeneous opacity, more on the right side. Here is the picture where you can see in the hypertrophic cardiomyopathy, there is enlargement of the heart muscles. The other picture, which just shows how the chambers are enlarged and there is an increased volume in the left ventricle. This is another picture of the left ventricle due to dilated cardiomyopathy, which has been highlighted. The patient was on CPAP, and the patient was with the following medications like diuretics, digoxin, cardioprotective drugs, and antihypertensives. Along, she was covered with IV antibiotics of injection Taxim for 5 days. The patient was symptomatically better and was shifted back from the intensive care unit on the 5th POD. Following, she was on the following medication along with injection heparin 5000 units subcutaneously BD for 5 days. The fluids were restricted to 800 ml per day. Patient symptomatically improved. The patient was advised to do a repeat echo after 1 week. The patient was advised discharge with the following medications with cardioprotective drugs, antihypertensives, and diuretics. Coming to the topic per se of pericardium cardiomyopathy, it is an unusual form of dilated cardiomyopathy of unknown etiology. It occurs in previously healthy women in the final months of pregnancy and up to 5 months after delivery. There is 0.1% of pregnancy can lead to devastating consequences with overall morbidity mortality rate as high as 5 to 32%. Etiology, we have the cardiovascular stress of pregnancy, which is due to increased fluid load, inflammatory response in pregnancy due to elevation of tumor necrosis factor alpha and interleukin 6, pathological autoimmune response to fetal cells that lodge in the maternal circulation and cardiac tissue, nutritional deficiency like selenium. The risk factors which includes are age of parity, either younger age or the elderly gravida, the number of pregnancies, multiple pregnancy, preeclampsia, gestational hypertension, oral tocolytic therapy, beta-adrenergic agonist. The signs and symptoms are dyspnea, which is shortness of breath, orthopnea, unexplained cough, pitting edema in lower extremities, excessive weight gain during last month of pregnancy, palpitations, and chest pain. The following is the diagnostic criteria of hypertrophic cardiomyopathy, like development of heart failure during last month of pregnancy or within 5 months of delivery. The second point, which includes the absence of an identifiable cause for the heart failure, the absence of recognizable heart disease prior to the last month of pregnancy, and the left ventricular systolic function determined during echocardiography with an ejection fraction less than 45%. The treatment is similar to that of the congestive heart failure, which includes the diuretic, beta blockers, whereas in pregnancy, AC inhibitors, angiotensin converting enzyme inhibitors are contraindicated. Therefore, we give hydralazine and nitrate, which may replace the ACI inhibitors. If the ejection fraction is 35%, anticoagulation is indicated as a risk of developing left ventricular thrombi, as in my case. About 50% of the women, the clinical and the echocardiographic status improves and returns to normal, whereas the disease progresses to severe cardiac failure and even sudden cardiac death. 30 to 50% are at risk of recurrence of left heart failure and the death in the subsequent pregnancies. Therefore, the diagnosis is challenging since most of the women in the last month of normal pregnancy or soon after delivery experience dyspnea, fatigue, and pedal edema, as in my case. Hence, the treating physician should have high index of suspicion and consider it when managing dyspneic patient for this potential lethal condition. Here are the review of the literatures which was done in, it is an original article, and here we have a conclusion where the left ventricular function is a prognostic factor and which is the most important parameter for the counseling of the patient with peripartum cardiomyopathy. And the other journal where we have the conclusion that it has a history of subsequent pregnancy, there is an increased risk with a decrease in left ventricular function and the clinical deterioration and even death. And you have even a journal of pregnancy where the same thing is indicated with the diagnosis is challenging. And here in Texas Heart Institute also, we have a review of literature which shows a combination of the environmental and the diagnostic criteria. The following are my references. Thank you.